Είναι μεγάλη και χαρά μας που έχουμε τη Huban Attila μαζί μας. Θα μου επιτρέψετε μόνο την προλογή στα αγγλικά για να μπορεί και η γυναίκα να καταλαβαίνει τι γίνεται. Dear Huban, it's a very great pleasure to have you with us. She's a well-known pediatric ophthalmologist with many international actions, and she's a very good friend of Greece, I believe. She's currently professor of ophthalmology at the Ankara University. She's the president of the Turkish Ophthalmological Society. She's one of the board members of the EBO. So she's very involved into education and training. And she's also the editorial board of Strabismus and the section editor of the Journal International Ophthalmology. The rest I will tell at the end. Dear Huban, please proceed.
Thank you very much for this generous introduction for me. I would like to thank for the kind invitation, and it's a great pleasure and honor for me to be here in your meeting and also in Athens. This is my second visit to Athens this year, and I'm so happy. I feel as if I'm at home, and I like it very much. Thanks a lot. And today my talk is what is new in Strabismus. This will be like a self-assessment, or I will look at my personal professional life, and especially when I hear jokes of my colleagues from other subspecialties like, what are you doing? What are you doing so many meetings and panels? What do you discuss all the time? You are doing the same thing, recession and resection. What else? And this, I try to criticize myself. I think, am I at the same place that I began when to my career, and or have I learned something through these years, because it will be like 30 years next year in pediatric ophthalmology and strabismus. So this, you will listen my self-criticism, and what I learned, I try to find it out, and I will be very happy if you tell me your experience through your careers. Are we doing always recession and resection at the same muscles? And I try to summarize the topics as extraocular muscles, anatomy and innervation, what's different in surgery when you compare through my lifetime, imaging, and what's new in amblyopia treatment. We all know that there are 6 extraocular muscles, about 3 to 4 centimeters in length, and we operate at the end of these muscles, and we try to titrate, we try to correct as much precise as we can do. And when I'm teaching to medical students, I usually say there are 3 actions, primary, secondary, tertiary actions of these muscles, and these are innervated by these cranial nerves. But also there are pulleys. Pulleys are in our agenda after 2000 with the works of Dr. Joe Dimmer, but they were already described in 19th century by Sapey. And later it was revisited by Robinson to make a digital eye model for surgical decision, and later by Miller to make a extraocular motility model with MRI findings. Pulleys are the structures that are taking place behind the equator, and they are continuous with the posterior tenon, and the main role of these pulleys are to keep the muscles on their route through the contraction and through the eye motility, so that the eye muscle will not flip over or get out of the way of the muscle actions. And some of the strabismus pathologies or pathogenesis are related to the pulley anomalies. And when there is anomaly of the pulley, this will cause the motility problem, the control of motility is disrupted, and the eye muscles can be complicated, and these can be the reason for the difficulty in understanding some strabismus. What can be these abnormalities? They can be developmental, or they can be associated with craniosynostosis, that all we know about the fourth nerve palsy and the head postures that we cannot easily correct with surgery. It can be traumatic, it can be age-related, like in sagging eye syndrome, or it can be related to abnormal laxity, like in Marfan syndrome or hyperelastosis. If there is pulley heterotopia, it can cause cyclovertical deviation, or like we can see the strabismus fixus in high myopia, and pulley instability can be the underlying cause of Brown syndrome. And imaging is the best method to detect these pulleys. If pulleys are responsible for the etiology, and then we can correct these with pulley surgery. In orbital trauma, especially in blowout fractures, we can see that after muscle release, we don't have the exact outcome that we wish. This can be related to the trapment of the pulley, so we should release the pulley to get better result. Also, during augmented tendon surgery, we try to change the pulley position with Foster sutures, and also in high myopia, as I said, or in sagging eye syndrome, we try to fix the position, repair the position of pulley for getting strabismus corrected. Extraocular muscles, we see them during surgery. They seem as if just one layer of muscle. Actually, they have two parts, two neuromuscular parts. The global part is continuous with the tendon, and it ends at insertion, and it's responsible for the bulbous rotation. It makes 50% of the muscle itself. The orbital part ends 60 millimeter behind the scleral insertion on the posterior capsule, and it's continued with the connective tissue pulley, and the orbital part has effect on pulley and keep the path of the muscle on the eye, and during contraction, pulley moves back, and during relaxation, it moves forward. Are the muscles only has layers, but they have also compartments. The compartments are more significant for lateral and middle rectus. It is less significant for inferior rectus, but not at all for superior rectus muscle. And for the obliques, we have that they have compartments for superior oblique, but not in inferior oblique muscle. Histopathologically and with imaging, it's demonstrated that there are well-defined and segregated compartments for the muscles, and functions can differ for upper and lower part of the middle and superior rectus muscle. And this change our knowledge, we say that the middle rectus muscle has just one function, it is adduction, and lateral rectus abduction. But with these compartments, horizontal muscles also have activity during vertical ocular movements and fusional vergence. And these are responsible for the pattern strabismus or compartmental strabismus. Also, these compartments have different innervations, like lateral rectus muscle have two branches of the lateral rectus muscle, and if only the upper part is affected, esotropia will be less prominent. We call it usually palsy. And if both parts are involved, both the superior and inferior, we see more esotropia in primary position, and we usually call it palsy. The other is paresis, sorry, this one is palsy. And we can detect decreased volume of whole muscle, not only the superior or inferior part. And this will be reflected in our surgery also. We can do single muscle transposition or just plication or partial resection of the muscle to correct its esotropia. Middle rectus muscle also has superior and inferior compartments, and the superior part has more contraction in adduction when we compare with convergence. The lower part is more active in convergence. And with asymmetric tendon surgery, with slanting or with partial tenotomy, we can correct these different kind of strabismus. And as you all know about the superior oblique muscle, its anterior part of the muscle is more close to equator and have more torsional effect, and the posterior part have more vertical action, and this will result in torsional diplopia and or vertical diplopia according to the affected part. And also this will affect our treatment, as you can do Arada Ito, this well-known surgery, and partial tenotomy. Imaging has evolved during this time, and MRI is our preferred technique for muscle with higher soft tissue resolution for detecting muscle pathologies, and it has no radiation effect. And the coronal images are better in showing extraocular muscle pathways and innervational status. In addition to coronal images, with the axial images, we can see the horizontal recti and with sagittal images, we can see vertical recti muscles. And for sagging eye syndrome or the pattern strabismus, we can do imaging, or in thyroid eye disease, we can do imaging to find out which muscle should be operated. Also in these imaging, we can see the muscles better, and we can see, detect and measure the muscle volume, and we can detect the places for pulleys, and again we can decide our surgery accordingly. It's better to measure the amount of muscle around 6 to 8 millimeter behind the bulbus, and this is the area where extraocular muscle have the maximum area. And in total paralysis, the muscle volume, when we measure the muscle volume, it decreases to about half of it. In paralysis, there is usually partial thinning and asymmetry due to denervation. What can we do for measuring or screening strabismus? Is it easy to, because there are so many technological devices, will it be better to use these devices so that we can more accurately measure this amount of strabismus, detect strabismus, or screen for it? There are many devices. When you look at literature, these are just a few examples, but these are not easy in young or babies or young children, and also it is time consuming, and it's also not always reliable. So even though with these technological devices, I still more rely on Hirschberg sometimes, but usually uncover tests. And this also gives the opportunity to have time to have interaction with the children and to measure, have more communication and measure more accurately. Maybe this is old-fashioned, but I rely on this more. And as you all know, OCT is a revolutionary change for retina with a retinal subspecialty and anterior segment specialty. Can we use it? Sure, we can use it. We can decide about the insertion of the muscles, where to find it, especially in consecutive cases or residual cases, or after trauma, or in complicated cases, whether to look for lost muscle or a tendon stretching syndrome. And genetics, as you listened in the morning in the perfect lectures and the talks, genetic is very important in treatment, but also it has changed our classification. For many different diseases, now we have a common syndrome, congenital cranial dysnervation syndrome and fibrosis syndrome, so this also makes easy for us to understand the etiology and pathogenesis. Surgery, what has changed? When I first began my strabismus career, we believed that 5 or 6 years was early for surgery, because it's usually said that at that time 18 years is okay, because the development of the child will be at that time completed and you can do surgery. So we were more on the worth side, and we say that surgery can be done at any age because there is an inherent absence for fusion. However, with the literature and the evolvement, we know that it's better to do surgery as early as possible. And what is early? Now we can operate. I try to operate before 1 year of age, as soon as there is no change or still the child has a strabismus. And unfortunately, in my country, still strabismus surgery is accepted as aesthetic, and most of the insurance companies, they try not to pay for it. The social security system pays for it, but the private insurance companies, they accept this as aesthetic. Even though we try to change this, we say that this is a functional gain. Also, this is something not normal. Usually in aesthetic surgery, they do operation for normal functioning nose or ears, but in this case, this is not normal, but I hope we can manage to change this attitude so that they can pay for it. And there are new surgery techniques like minimally invasive strabismus surgery that gives us the opportunity to operate with minimum tissue disruption, with faster rehabilitation and better outcome. And also with the microscope, we can do vessel sparing surgery, even a little bit more time consuming. It's important, especially in elderly or reoperation cases, to decrease anterior segment ischemia. Toxins are relatively new because I can say this is like 40 years maybe, but they are effective, especially in thyroid diseases or in acute cases of strabismus, and it can give us a prediction for the strabismus surgery. What about robotic strabismus surgery? Because robots are taking more place in urology, gynecology, neurosurgery, and this is the first paper with Da Vinci robot. It was performed in Strasbourg, I guess. It's the robotic strabismus surgery. Still, there is a surgeon there operating the robot, and it said that it's more precise with this one. But these robotic surgeries are not precise in intraocular surgeries yet. They are fine with the 6-0 vicryl or 5-0 sutures, but not with the 9-0 or 10-0 sutures. And it needs a learning curve to use this robotic surgery. So what will be the next? Shall we be replaced by surgeon robots? I hope not. At least I will not see this, but I don't know for the next generation. And AI is very popular in all subjects, and will it affect our subspecialty? Definitely we'll see it, especially in preoperative planning. AI algorithms can analyze the preoperative images, and it can help us to determine the best surgical planning, and so that we can predict the outcome. It may assist in surgery, and we can see the outcome prediction with the machine learning. We can analyze the large data, and we can predict the likelihood of surgical success or the potential complications. And it may, robotic integration can be seen, as I said before, and postoperative monitoring can be done with this AI tools, so that the patient recovery through the images can be analyzed and followed with early possible complications. So what is new in amblyopia? Because I'm sure that you also heard from your patients, like sometimes the father says, oh, I was doing patching when I was a kid. Will you again tell me to do patching in my child also? There are so many technological advances, and are you still doing patching? We know that brain plasticity continues after 12 years of age, but we cannot have as much as success as we like after this age. And also there is this controversy. Do we worsen with occlusion? Do we interrupt with the monocular viewing, binocular viewing by doing occlusion? There are pharmacological agents. They were promising initially, but especially levodopa and citicoline. But when you discontinue them, their effect will be gone. So, and as we cannot use them for lifelong in children or in young adults, it's not as promising as they are initially. And liquid crystal glasses, they can be alternative to occlusion, because the children usually have better compliance with this. And also we can do the correction with the glasses behind these crystal glasses. We can also monitor the child whether using or not. And the child most children like it, especially in summertime, like having sunglasses, and they don't realize that they are doing patching. With the 15 seconds occlusion, the vision comes and go in the better eye, so the child can have better compliance with this. But you have to tell the patient to have this double the amount of your occlusion time. The cost was the major concern initially, but it's cheaper now, and it's better aesthetically. And binocular treatments, as I said, more popular, like decoctic games and films, and this is the Tetris game you all remember. In these games, simultaneously different images were shown to both eyes, and with the polarized glasses or colored glasses, contrast in the sound eye is decreased, while the contrast in the amblyopic eye is increased, and at the same time the suppression can be decreased. There are modified version, modified iPad, Oculpad games and films, but as in many things, when you say the child that you have to play this one, usually they don't like it. They don't like obligatory things, and they want to different games. They say they don't want to play the every day the same game. It's similar to video games. These are like virtual reality. It's one of them, Luminopia, was approved in States also. Compliance can differ in this one also. So what I have learned, anatomy of the extraocular muscle and innervation are different than I learned previously, and binocular treatment modalities are promising. We tried some of them, but they are not still superior or alternative to our basic classic occlusion therapy. And in imaging techniques not only change our understanding of the etiology and pathophysiology, but also they help us to surgical planning for better outcome. We can use anterior segment OCT and UBM for detect muscle insertion size, and artificial intelligence, I hope, will give us the opportunity to have better configuration of the orbital and extraocular muscle structure so that we can customize our surgeries and treatments for our patients. And we'll have better surgical outcomes. So what happened at the end of this third year? I'm still doing recession resection or similar type of surgery, but with time I admire eye more and more. And even every single fiber has very important role, and I'm doing with more respect, I should say, try to make conservative as much as possible. And before finishing my talk, I would like to invite you to our National Congress that will be in Antalya at the end of November. And more than this, I think you will be more interested. The European Strabismus Association meeting, it will be together with American Pediatric Ophthalmology Society, will be held in Istanbul next year, June. I have the brochures for you, leaflets. I left them in the registration desk and just next to the technical desk there. And I would like to be so happy to host you in Istanbul in June. The weather will be nice, and I hope it will be a good opportunity for you to have this meeting together. And at the same meeting on the first day, just one day before Strabismus meeting, there will be subspecialty exam of European Board of Ophthalmology, and it will be a good chance and opportunity for you if you are planning to have this exam. It will be very close to you. It will be in Istanbul. Hope to see you there, and I will be happy to have questions or your contributions and comments. What else do we do different in this time?
I would like to thank Professor Attila for this excellent presentation. She gave us all the new and important stuff in strabismus, and I hope with this presentation we'll attract more young ophthalmologists to strabismus, because until now it was probably one of the fields in ophthalmology that there was no action, there was no gadget, there was no technology, but now with what you showed us, we got artificial intelligence jumping in, we got imaging, we got video games, so that will be more and more attractive. Are there any questions for Professor Attila? May I ask you what you think it will be, which of all these new things that you showed us, the new gadget, you are actually using right now? What was the newest device or technology like anterior segment OCT that you're currently involving in your everyday practice?
OCT is the one, anterior segment OCT for muscle insertion, but I'm not a good technical person, so I still want to have the interaction with the child, measure it. And in some of these technological things, we need an examination under anesthesia. It's not so always easy to perform them. So, and also while doing our jobs or daily practice, we don't understand that we are using those devices also. I realized that when I got through the years, I thought that, oh, we are at the same place. In Strabismus, there is no technological advances. But when you look actually in the everyday, especially like in sutures or surgical instruments, we have so many developments. When I was first resident, we were using the sutures with the needles. We were threatening it's all days. But now we are using 6-0 vicryl, so they are actually important. We cannot notice or appreciate it maybe, but there are, with the microscope and everything, there are so many technological advances. I hope the young ophthalmologists will like it.
Thank you.
Thank you.
Mina, you have one more question. One more question for you.
From parents to operate early on a strabismus case on their child, and do you take that into account in your decision? If the parents ask for early intervention for strabismus, is it something that you take into account? How do you deal with it?
The pressure is usually coming from the accommodative esotropia patients. The parents, they don't like the idea of getting strabismus when they get out, they take off the glasses. They want their children to be perfectly aligned even without the glasses. That's the most pressure that I got. I make them frightened. I usually say, okay, we can operate, but when he needs the glasses, he will go out, if you like it. And for infantile esotropia, they don't ask me to do early surgery. I usually offer them to do surgery because still we have the old school thinking in the society or in the population. They say that, oh, this is more aesthetic things, so let's get it before school or at a later age with a decreased complication rate for anesthesia. So I'm usually the one forcing for early surgery in infantile cases. But for accommodative esotropia, usually the parents ask for it.
Thank you very much, and we promise to be a good Greek crowd in Istanbul next year.
Thank you.
Thank
Hope
you.
to see you there.
Μια που θα προεδρεύσω και της επόμενης συνεδρίας, σκέφτηκα να πάρω αυτή την αφορμή με αυτά που είπε η Χιούμπαν. Οργανώνει, όπως καταλάβατε, το επόμενο συνέδριο της Ευρωπαϊκής Εταιρείας Στραβισμού στην Κωνσταντινούπολη, 11 με 14 Ιουνίου, το οποίο είναι ταυτόχρονα μαζί με το APO στην Αμερικανική Ακαδημία Παιδοφθαλμολογίας και ένα πάρα πολύ ωραίο συνέδριο. Κάτι που είπε είναι ότι την παραμονή αυτού του συνεδρίου θα είναι οι Ευρωπαϊκές Εξετάσεις Παιδοφθαλμολογίας και Στραβισμού. Είναι κάτι που ξεκίνησε το 2018. Ήμουν από αυτούς που συνέβαλαν όσο μπορούσαν να ξεκινήσουν και η επόμενη χρονιά θα είναι η 5η του χρονιά. Θα ήταν πολύ ενδιαφέρον να έχουμε περισσότερους Έλληνες που θα πάρουν αυτό το δίπλωμα της Ευρωπαϊκής Εταιρείας, δηλαδή να είναι του EBO, fellow, όπως παίρνουμε το γενικό EBO, να μπορούν να πάρουν το EBO Strabismus και παιδοφθαλμολογίας. Και θα ήθελα με αφορμή αυτό, γιατί πιστεύω ότι ήταν μια παράληψη της εταιρείας μας και εγώ σαν προηγούμενος πρόεδρος το παρέλειψα, να τιμήσω και να αναφέρω ότι υπάρχουν 3 Έλληνες οι οποίοι έχουν πάρει αυτό το τίτλο μέχρι στιγμής και ονομαστικά θα πρέπει να πω ότι ήταν η κυρία Μαργαρίτα Παπαδοπούλου η πρώτη, ο κύριος Λάμπρος Λαμπρογιάννης ήταν ο δεύτερος και η κυρία Κούρτη Περσεφόνη ήταν αυτή που το πήρε φέτος στο Παρίσι. Θεωρώ λοιπόν ότι σαν εταιρεία έπρεπε τουλάχιστον να τους αναφέρουμε, αν όχι να τους τιμήσουμε, και ελπίζω του χρόνου στην Κωνσταντινούπολη να έχουμε τουλάχιστον έναν ακόμα Έλληνα. Σας ευχαριστώ πολύ.